Welcome back to Season 3 of 12 Days in March. In this multi-part series, we will focus on the key derivatives related to blood pressure regulation and the associated disorders you will need to be familiar with for Step 1. I should clarify that this is not an exhaustive review of hypertension. Our focus with this, and all videos, are to focus on the major takeaways that will help you negotiate your way through blood pressure vignettes come test day. As with this and all presentations, a free PDF is available for download at the website. I am most pleased to see this material popping up all over the internet. I especially like when they delete my name. That's a special treat. In a nutshell, this is the junk we'll be covering. In a bigger nutshell, this video will address blood pressure regulation with a focus on the autonomic nervous system and the role of the kidney in regulating blood pressure and restoring blood volume. Do note, we can begin thinking about the immediacy of those responses with the autonomic nervous system responding to pressure changes in seconds. Oh, and here's the best part. If you behave, which you don't always do, I'll toss in some special situations where blood pressure plays a key role in sorting out test vignettes. So let's get started. Here are the main players. You should understand that our resting tone is set by the sympathetic vasoconstrictor center located up in the medulla. Through this regulatory center, we maintain a baseline level of vessel contraction. That is referred to as vasomotor tone. As you are aware, our blood vessels have a rich innervation of sympathetic nerve endings, with norepinephrine being the principal neurotransmitter, stimulating the alpha-adrenergic receptors. I've included an image of Meyer waves, which simply reflect the regular oscillations of blood pressure in response to signals from peripheral baroreceptors. These cycles or adjustments occur approximately every 10 seconds. So here are the key players. The baroreceptors, also called mechanoreceptors, are located in the carotid body and aortic arch. These receptors respond to stretch. When stretched, implying that perfusion pressure is adequate, parasympathetic impulses are triggered. These afferent impulses are transmitted by cranial nerves 9 and 10. The increased parasympathetic tone inhibits sympathetic outflow. So we have baseline vasomotor tone sent centrally through sympathetic outflow. If that tone becomes too great or high, the glossopharyngeal nerve and or vagus nerve turn off sympathetic efferent output. Whereas this is not a deal breaker for the boards, it is interesting to note that the baroreceptors are more sensitive to changes in blood pressure rather than the absolute value. That is, they can essentially reset their baseline tone, which makes sense since we know that patients do develop hypertension. Once reset, we see those normal oscillatory waves, albeit at higher pressure values. With that background, we can start digging into the major derivatives. Although we just reviewed the autonomic nervous system response to wall stretch, that is way less exciting to the question writers in Philadelphia. They are much more interested in the response to the opposite state, that is, arterial hypoperfusion. It's just more exciting. So what happens? With arterial hypoperfusion, we know that the parasympathetics have checked out, leaving us with increased sympathetic outflow, and we know the blood pressure is a function of cardiac output and total peripheral resistance. So what does that heightened sympathetic outflow buy us? Well, by formula, you can see a beta-1 stimulated increase in heart rate, as well as a beta-1 stimulated increase in stroke volume by way of the inotropic effect. We already mentioned the blood vessels themselves are richly innervated with alpha-1 adrenergic receptors. When those are stimulated, we get both vaso and venoconstriction. Relative to the venoconstriction, the more blood that returns to the heart, the more it will pump. So what does this look like? With arterial hypoperfusion, alpha-1 nerve endings are stimulated, resulting in arteriolar vasoconstriction and increased total peripheral resistance. With venoconstriction, we see an increase in venous return. This translates into an increase in stroke volume that also contributes to restoring normal perfusion pressure. And here's the beta-1 side of the story. The chronotropic effects occur due to stimulation of the sinoatrial node, whereas the dromotrophic effects occur due to an increased speed of conduction through the AV node. And finally, the pressure volume loop on the right highlights the inotropic effect with an increase in stroke volume. All these effects combine to restore a normal arterial pressure. Well, this is a happy coincidence because this is the same response we discussed when reviewing the arterial hypoperfusion associated with congestive heart failure. The autonomic nervous system does not discriminate. The baroreceptors will either be stretched or they won't. That said, let's move on to the humoral arm of the neurohumoral response. And let me conclude this presentation on blood pressure regulation and the autonomic nervous system. In the next video, we will pick up the more important discussion focusing on the role of the kidney in blood pressure regulation. If you have any questions or concerns, please drop me a post at 12 Days. Thank you.